Good morning. My name is Jessica Covington, and I'm the Quality Program Pharmacist for the Kentucky Hospital Association. Thank you for joining us for today's KHA Quality Webinar Series. This session is being recorded and will be available to you shortly. As a reminder, our speaker will be taking questions at the end of the session. So we encourage you to participate by putting your questions in the chat box or unmuting yourself. Today's presentation, The 4 Levels of Care in Hospice, How to Keep Your Patients Out of the Hospital, presented by Dr. Greenstein, is a part of the Kentucky Rising Stars program to improve CMS star ratings for the readmission measures. During her presentation, she will provide educational tools to improve the quality of care for hospice and palliative care residents while reducing transfers to the hospital. She will discuss who qualifies for hospice, the continuum of palliative care, as well as review the 4 levels of hospice care. At this time, I would like to introduce our speaker, Dr. Greenstein, the Medical Director of Vetus Healthcare and Clinical Associate Professor of Family Medicine for Ohio University Heritage College of Osteopathic Medicine. She graduated from Ohio University Heritage College of Osteopathic Medicine with the Doctor of Osteopathic Medicine degree. She holds several professional certifications: the American Board of Wound Management, American Osteopathic Board of Hospice and Palliative Medicine, and American Osteopathic Board of Family Physicians. Thank you so much for being here with us today, Dr. Greenstein, and I'll turn that presentation over to you.
Good morning, everyone. And thank you for joining us. I wish I could see you in person, but I know you're all out there with cups of coffee and smiling faces. So I'm excited to give you this presentation. I think it'll be helpful. My objectives are to really help you understand the hospice Medicare benefit and be more comfortable when to refer to hospice, who qualifies for hospice. We'll talk about a little bit about what hospice patients look like, and definitely how hospice can help keep your patients in your facilities. There's a lot of talk about palliative care versus hospice care, and so we're going to talk about that, the continuum of palliative care. And then a lot of people don't realize that there's actually 4 levels of care when you have a patient on hospice, and we'll go through those. And some of those levels are very helpful in keeping your patients out of the hospital. So we'll go over some examples of how to utilize hospice and those levels of care effectively. So my first question, and we can kind of use the chat box for this, is what is the average length of stay on hospice in the United States? And this is pretty much an average across all hospices in the nation. How long are patients on hospice on an average before they die?
We have 3 days, 79 days, 20 days, and a week.
Okay. We kind of got all over. We got the short end and we got the long end. So I know people are thinking. So the average is about 2 weeks. Now, I think somebody said 79 days because they're thinking of maybe, well, 79 days would almost be kind of a perfect length of stay for hospice. So hospice is meant to be a 6-month benefit period. As you know, some patients are on as long as a year, year and a half, but 2 weeks is really too short, right? These are patients that are being brought on service too late. So they have 2 weeks or less to live. A lot of times we even see patients on for a day, 2 days. And at that time, they're in total crisis mode. They've been admitted because they are dying and probably dying uncomfortably. So it's a full court press to get them comfortable and situated, and then, and hopefully that hospice can get them to die comfortably pretty quickly. But that's not what we want to do. We really want to see the patients be admitted on hospice much sooner than that, so they can really take advantage of the full benefit. And so that'll be another thing that we talk about. So here's a graph from 2013. This was some years back, and we'll move forward from this. But as you can see, back in 2013, the biggest pie graph shows that the length of stay across the nation for hospice was less than 7 days. The next pie graph is 8 to 14 days. So you can see that half of the pie is all the patients on hospice across the nation. Half of them are not on for more than 2 weeks. Our sweet spot is going to be around 90 days. And so that's when we have plenty of time to get to know the patient, be able to take care of all their needs, help the family, hopefully get through some bucket list items for that patient, get their pain and symptoms all under good control so that they can die in their place of choice peacefully. But as a nation, we're not doing very well with this. So if we move forward to 2016, things aren't much better, right? We still have half the pie with 14 days or less. And then I don't have a pretty pie piece for recent years, but this was reported in NHPCO, National Hospice and Palliative Care Organization, that the median length of service in 2020 was 18 days, which has changed little in the last 15 years. So the big question is, why are we referring so late to hospice? And I think a lot of this is that people are afraid of hospice. And the fact that half the patients are dying within 2 weeks perpetuates that fear of hospice. Because when we get a patient on hospice and they are uncomfortable, their respiratory rate is 40, they're breathing very fast, they're tachycardic, they may be very restless and trying to get out of bed, and are at risk for breaking a hip, that is crisis mode for hospice. And these patients a lot of times are unable to swallow at this point. So we're giving their meds in high concentrations sublingually to get their symptoms under control. And the meds that we use, morphine, which is tremendously helpful for shortness of breath because it's a vascular med, and Ativan to help settle them down, as well as Haldol to help with terminal restlessness. We get them comfortable where their respiratory rate goes back down to normal at 20 and they're not restless anymore and they're able to peacefully pass. But this is over 2 days, 3 days, because we got the referral so late. And so we constantly hear, my patient, my aunt went on hospice. They gave her morphine and Ativan, and she died right after that. Well, that is because that referral came so late. So this is the sequence that we need to stop. We need to get patients on hospice sooner. It's a hospice Medicare benefit, and they are eligible for it, and they should be able to get the benefit of it for as long as they remain eligible. This study by the NHPCO shows what we've already been kind of talking about is beneficiaries who die with hospice. And again, this goes back to 2015 to 2019, and really half of our beneficiaries of Medicare are receiving hospice. So we're really only scratching the surface. I mean, we are in an era of baby boomers with a geriatric population that's much larger than any other subset, and we are not capturing the benefit period for these patients. And this is commonly what we hear and why patients are afraid of hospice. So, what are the misconceptions of hospice? Hospice means we do nothing. So, I've been a full-time medical director of Vitas Healthcare I'm going on 12 years now in the Columbus program. And it is a full-time, full court press every day. I have patients with med lists that are very long. There's patients that come on hospice and they're still on their Lipitor. We do a lot of education. We do a lot of med reconciliation, but we meet the patients where they are. So a lot of times patients come on and it's just enough to convince them about hospice after they, have all the fears of hospice. The last thing we want to do is take away all their medicines and tell them that, we're taking away all treatments. So they come on and their medicines are reviewed, certainly. We will constantly be reviewing risk versus benefit. A lot of these patients have outlived the benefit of some meds, i.e., cholesterol pills. And now, they may be contributing to muscle pain or pill burden. So we're always determining which meds are appropriate at the time, the patient is on service and as they progress on service. All treatments are discontinued. We do a lot of treatments in hospice. So I'm board certified in hospice and palliative care, but I'm also board certified in family medicine. And the most of what I do in my job is primary care. So, we are treating patients' urinary tract infections and, nausea and vomiting, shortness of breath, chest pain, depression, anxiety, rashes, gastrointestinal bugs. There is a lot of treatments that occur during hospice, and these treatments keep the patient from going into the hospital. So if we can treat a patient's UTI and keep them from going into urosepsis, then that is, helping the patient with their pain and suffering, which is what hospice is for. Depending on the hospice, there can be more complex treatments that are discussed and agreed upon. This is hospice to hospice. Some of these invasive treatments, such as ventilators, inotrope drugs like dobutamine, dialysis treatment, palliation, chemo, and radiation, these are very expensive treatments. And the hospice is not paid anymore for those treatments. And so that's why some hospice will say, we're not going to take anybody on dialysis. We're not going to take, that patient because they're on a very expensive med. And it's because they're not getting any extra money out of Medicare for that medication. So it depends on how that hospice can handle pretty much, their bottom line. Are they fluid enough hospice where they're making enough money on some of the lower expensive patients so that they can then, save that money to be able to spend it on more higher expensive patients? Hospices with low census are not going to be able to afford very expensive patients. So how hospice, the Medicare benefit payment structure works is hospices are paid based on what level of care that patient is on. So routine level of care is the most common level of care. That's when patients are on hospice, they're not in crisis, they're being, managed. These patients are getting, these hospices are being paid, let's say, $180 per day per patient. It's not based on diagnosis. So let's say we have a patient that has Alzheimer's and they can not swallow well. So they're not on many meds and they don't need many treatments, but they are terminal from their dementia because they're losing weight or preventing bed sores, all that stuff makes them appropriate, but they're not a very expensive patient for the hospice. Compared to an end-stage heart failure patient, comes out of the hospital, the cardiologist has put them on a dobutamine drip. This drip isn't going to be modified. The cardiologist has said, you're just going to be on this until it stops working. So now that hospice has to accept that patient with that med. And that med can be up towards $1,000 a week. So they're still getting paid the same amount of money from the hospice Medicare benefit for the other patient, but the cost has gone up considerably. So that's what determines whether a hospice will say, yes, I can take that patient or not. Um, let's move on. So the next thing I want to talk about, because we're talking about these treatment interventions, is this hospice continuum and palliative care continuum. And you'll see this picture, which it kind of looks like an avocado kind of cut in half. I really like this visual. All hospice, the purple in the middle, is palliative care, but not all palliative care is hospice. So that's what we need to determine is when a patient's start of palliative care becomes when they're appropriate for hospice. And we'll get lots of phone calls from family doctors or patients saying, I need an evaluation because I'm interested in palliative care. Well, who's doing palliative care in the community? Your family doctors, cardiologists, internal medicine, all primary care doctors are doing palliative care. There isn't any specific palliative care doctors out in the community. It's your primary care doctors and your geriatricians. So their patients are coming into them and saying, Dr. Smith, I'm really tired of going to the cardiologist. Could you take over care of my cardiac meds? And then they say, sure. And then 2 visits down the road, the doctor's noticing that their blood pressure is very low. So now they have to back off on blood pressure meds because the patient has lost 10 pounds and now they're not tolerating their blood pressure meds. That's all palliative care. That is helping the patient age in place with the decline that they're having through their body systems changing. Now, that primary care doctor is going to do that palliative care until they get to the point where they're now hospice appropriate. And that may be that the patient now, for a cardiac patient, is on oxygen 24 hours a day, has a New York Heart Association class 4. They're starting to have advanced dementia. Their appetite has been, or their diet's been modified because they can't swallow well. Now that's becomes a hospice appropriate patient, and the hospice will help that family doctor continue with the palliative care until they die. So there is a continuum, and there's a lot of things outside of the hospice palliative part that primary care is in charge of. And that may be more aggressive things, like a patient wanting palliative radiation and chemo. They want 15 treatments before they consider, stopping anything. A lot of times a hospice will say, well, we're just going to wait until you complete those treatments and then you can come on hospice. Because again, the Medicare benefit isn't going to pay for those treatments, but yet their Medicare Part B will. So we have to determine case by case when a patient is appropriately reached the palliative care part of hospice. So we need to see palliative care as a continuum depending on the context of the patient's medical reality. When an illness is early on, palliative care assists in goal setting and symptom management while traditional therapies continue, i.e., that's what the family doctors, cardiologists are doing. As the illness progresses and the patient declines, then there is that tipping point. So we see them fall into the purple circle, hopefully. At this tipping point, hospice is a viable option. Hospice is able to continue palliative care to support the patient and the family as their treatment choices and options become more restricted. Hospice is able to bring in multiple core disciplines to assist in this care. So that's when they come on hospice and they get a hospice interdisciplinary team to help care for them. This includes the patient, of course, and their family. We always want to include the attending physician. They remain part of the patient's care team. They'll get an extra physician, which is the hospice physician or medical director. They may get the NP that works with the hospice. Then they get a registered nurse assigned to their case, a hospice aide assigned to their case, social worker, chaplain, and volunteer. And this entire interdisciplinary team helps take care of that patient. And if they're appropriately referred at a reasonable time, that team can take care of that patient for 6 months and provide them with a final good death. So let's talk a little bit about patient eligibility. So patients are appropriate for hospice when they have a life-limiting illness. When a life expectancy is 6 months or less, if the illness runs its normal and unexpected course. So this is a prognosis that is certified by two physicians. Ideally, it is the attending physician and the hospice physician. Those two physicians need to decide that, yes, the patient is appropriate. So a lot of times when we get referrals from a facility, I will always make sure that the attending physician is aware of the referral and is agreeing that the patient is hospice appropriate. There are times when I've called the attending and said, this is what I'm seeing, and I think the patient is still too early. What are you seeing? And that physician may say, oh, well, their wife just died and they've been married 62 years and he's just going to go downhill. Well, he knows that patient far better than I do. And there are some non-tangible reasons patients decline. So with that information, that is appropriate for the patient to be admitted along with the other declines that we may be seeing. But, part of my job is educating physicians and nurse practitioners and PAs because a lot of them are, and I was like this as a family doctor, we feel like we need to be exact on that last 6 months of life. And it it's not an exact science. So a lot of times we'll phrase it, let's see, it's May, right? We'll say, do you think Mrs. Jones is going to be around at Christmas time? And the provider says, oh my gosh, she's been in the hospital already 3 times since the first of the year. So no, I don't. That patient is hospice appropriate. So we need to start presenting it in more of a functional status way rather than that exact 6 months. The patients can be on hospice longer than 6 months. At time of recertification, if they meet appropriateness at that time, then they're recerted for another recert period. And we'll go over that a little bit. So the Medicare hospice benefit came out in 1982. When patients are eligible and admitted to hospice, the hospice will cover 100% of the costs related to the terminal diagnosis. Excuse me. This includes all their HME that they need for their comfort. So, hospital bed, overbed table, shower chair. They may need a Hoyer lift, a Broda chair, oxygen, nebulizer machine, any equipment that helps with the patient's ability to stay functional as they decline. Pharmacy. So the hospice will cover all meds related to the terminal diagnosis. So let's say a patient is brought on for end-stage heart disease. Then all the meds related to the heart are going to be covered by the hospice Medicare benefit. So in my case, we have a national pharmacy that we use, and all these meds are going to come FedEx to the home. So these meds would include, their Lasix, beta blockers, all that. But then we also would include comfort meds, such as their anxiety meds, their meds for insomnia. Um, we may put them on a med to get them eating better. What's not going to be covered, but yet is still going to be prescribed by the patient's family doctor through the local pharmacy, would be other diagnoses, such as meds for diabetes, meds for their thyroid, for glaucoma, um, for their cholesterol. So that's how the medications work. The medications that fall under our costs have to do with the terminal diagnosis as well as prognosis. So, and at time of admission, we determine which meds are related and which patient meds are non-related. We talked a little bit about the services are primarily reimbursed on a per diem basis, and we talked about that hospice is getting a certain amount of money per patient per day based on the level of care that they're on. So if a hospice has 150 patients on service and all of them are on routine level of care at that day, then that hospice is getting paid $180 per day per patient. If they have one of those patients on a higher level of care, then that patient has a different reimbursement. The higher level of cares are paid higher per day. And we'll talk about that as we move into those higher levels of care. So other things that are covered by hospice are doctor services. So they will get the hospice physician additionally overseeing the case in addition to the attending. They may, depending on the hospice, they may get house calls. I make house calls all the time. My nurse practitioner makes house calls. We do a lot of symptom management. We do wound care. So, depending on the hospice, you may have the doctors visiting your facility or the nurse practitioner for reasons in addition to just completing a face to face for eligibility. They're there for symptom management. Nursing care. Hospices will assign an RN case manager to each patient, and those nurses will be in charge of the plan of care. They typically see the patient between 1 and 3 days a week, depending on the care needs of the patient. We talked about medical equipment, medical supplies. This depends on each individual hospice, whether they're going to supply chucks, um, baby wipes, stuff like that. Wound supplies, if the hospice is managing that wound, those supplies should all be supplied by the hospice. But this would include Foley's, oxygen. I mentioned the wound supplies, and then, sometimes we'll need to order a suction machine. It just all depends on what that patient needs. We talked about medications. And then the patient will also get a hospice aide. And this hospice aide works under the direction of the RN case manager. They develop a care plan, and they're determining whether the patient is going to receive bed baths or be taken to the shower. Maybe that hospice aide's going to feed that patient once a day when they're there for lunch. But these hospice aides are not there for extended periods of time. So sometimes we get calls for a referral, and we have a patient that needs more of a sitter, or the caregiver can't leave the house at all, and so they need help in the house. That is not really the job of a hospice, and the Medicare benefit is not going to pay for us to be there for that type of custodial caretaking. Unfortunately, that's where the family needs to look into private caregivers, or maybe they're Medicaid eligible and they can get something through Medicaid services that that state provides. But our hospice aides are there for a set reason, part of the plan of care, getting that patient a meal in, getting that patient bathed and dressed and ready for an activity. Um, it has to be part of a care plan. Other services that could be provided by the hospice, um, physical and occupational therapy. These are very short stints. This may be utilized if somebody just got to a facility from the hospital and they are having trouble moving from bed to wheelchair. And so we will authorize 2 to 3 sessions for PT to kind of help that patient. Um, but again, this is not paid. The hospice doesn't get paid anything in addition. So this hospice is paying out of pocket for this physical and occupational therapy. Um, Patients cannot receive physical and occupational therapy skilled at the same time they're on hospice. Those are two hospice or two Medicare um, benefits, and they can't go at the same time. So the physical and occupational therapy that the hospice would be providing would be more restorative type. Um, Speech and language pathology service in a facility, at times the family is asking to um, see if they can move up from a mechanical soft diet to a regular diet. We would need a speech and language pathology service to come and assess that to make sure they can go up on that diet. The patients will get visits from the hospice social worker to help the family and the patient regarding financial things. If they need possibly the sitter, they may, help them gather names of companies. They may help with funeral plans. Social workers also do a lot with contacting family. Um, depending on the complexity of the case, there may be estranged daughter. Social workers do lots of different services for patients. Um, some The hospices may have a dietitian on service, and they are periodically consulted to help possibly with getting some weight on the patient. We sometimes bring on very complicated patients from Ohio State, and they may be on TPN. And so we need to work with a dietitian to determine what TPN that we're going to utilize that will be safe at the home. And then the hospices have bereavement managers, and they are working with the patients for anticipatory grief prior to the patient passing, and then post um, death. I think this piece is what is definitely lost in patients and families when somebody is only on for 2 weeks. Studies show that the families are just not as engaged and not participating in the bereavement services that are offered by the hospice. All hospices are required to stay in touch with the caregivers of that patient 1 year after, with phone calls and offerings of support groups and all that. But if the patient's really only on 2 days to 2 weeks, we really find that they're not participating in the bereavement. And that's unfortunate, because the hospice care team wants to be a part of that patient's family, just as you guys do. And so we want to be there for the family when that patient passes. And that's not always the case if it's such a short, intense stay on hospice. So the values of hospice. I mean, hospice and palliative care providers are experts in managing patients' pain and symptoms. We assist the patient with not only their physical pain, but emotional, psychological, and spiritual, because we have a full interdisciplinary team to help with all aspects of pain. We provide needed medication, supplies, and equipment. Um, the education is key. We are instructing the caregivers on how to care for the patient. A lot of times patients come out of the hospital and the families just don't know how to take care of their patients or their family members. And with education, they become very competent at how to turn a patient, how to prevent bed sores, how to clean patients, how to feed patients. And it just makes them a lot more successful taking care of their loved ones. And then our biggest aim is to ensure that the patient dies in their place of choice. If we were to interview 10 people, 9 out of 10 will say they want to die at home. Most patients do not want to die in an ER, an ICU, or a hospital. We know that. But unfortunately, if the patient keeps going out to the hospital, they're eventually going to die there. And so our goal is to get them on hospice so that we can keep them at home, whatever their home is. And this next slide shows that hospice is at home. And this could be nursing homes, assisted living facilities, or a patient's own residence or their daughter's house. The majority of patients in this graph from the NHPCO, and I have to put my glasses on to see, but this was 2021 assisted living facilities. So, and we know that. I mean, we're seeing assisted living facilities go up constantly everywhere. We at least are in Columbus, Ohio. So a lot of patients, that is their home. And the goal is to have them die in that home because the staff there is part of their family. So we're going to test knowledge again. What are the 3 top diagnoses in hospice? I do this so then I can have a sip of my coffee. I see if 2 in the chat box, 3. All right, so let me see. We got some good answers. Cancer, CHF, COPD, cancer, CHF, COPD. Wow, cancer, CHF, COPD. Everyone's doing the same thing, dementia. Oh, you guys are smarty pants. Okay, so let me get my graph here. The biggest pie is cancer. Okay, so, but if we take cancer and non-cancer diagnoses, the top one for non-cancer diagnoses is dementia. And then following that is heart disease. So yes, on average, the highest percentage are cancer patients. But the highest percentage of patients without cancer fall into dementia and heart disease. And I always feel that if you live to be 100 or over and you escape liver disease and any cancer and any neurological, we're all eventually going to probably die of either vascular dementia or heart disease. And so that makes sense that those are the top 2 non-cancer diagnoses. So good job. COPD is in here. It's a little lower, but that's a big one too. And unfortunately, we see a lot of the heart disease and lung disease because the predominance of smoking, which is unfortunate. So, what is the clinical criteria for hospice? So, we kind of have to think of it as far as functional status. Functional status. When a patient starts needing help with more and more activities of daily living, that is a decline in their functional status. And we have to ask ourselves, why are they declining? Is it because their dementia is declining and now they don't know how to bathe, dress, or toilet on their own? Or is it their heart and lungs and they're so short of breath, they're unable to do that? But once a patient starts having dependence in 3 to 4 activities of daily living, we really need to start looking at whether their diagnosis is now becoming a terminal diagnosis and they're functionally declining on a steady basis and now hospice appropriate. Now, we obviously also need patients' personal goals, that they don't want tremendous aggressive treatments. But typically, they're reaching a point where the burden of treatment is not as positive anymore, and they're not getting the potential benefit anymore. Their body is not tolerating increased meds because their kidneys aren't as good. They're not able to get adjustments in their cardiac meds because their creatinine is too high. So we start seeing that medications are less effective, or we need to even back off of medications. Weight loss. If we see patients losing 10% of their body weight unintentionally, that is a concern for their diagnoses contributing into this weight loss, and a BMI of less than 22. If we start seeing clinical progression of the disease, if we get the opportunity to have lab results and we see the creatinines worsening, they're anemic, they have multiple hospitalizations, increased utilization of healthcare. So we're doing diet modifications, we're doing stints of physical therapy, but they're not progressing with physical therapy. They're needing more things to help them. They're now on a nebulizer. They're not able to use their inhalers effectively anymore because they can't breathe in enough to get the med down in their lungs. They're needing more and more behavior meds because their dementia is causing them not to be able to eat well or puts them at risk for falls. This is all worsening of functional status. So if you get one thing out of the lecture, I want you to really think about patients' functional status. And when it starts declining, it's related most likely to a disease progression. Now, sometimes it's a UTI, right? And we fix the UTI and they get better. But if they're constantly getting an illness and they never really return back to their baseline, then that is a decline. We see this a lot in our COPD and CHF patients. They have an exacerbation, they go to the hospital, they come back, but they're not really the way they were before they left. They're now weaker, they now need a wheelchair, they're now walking with a walker. Those are all functional decline. And those are the ones that we want to pick up, because if they continue to have that type of trajectory, they're going to have a 6-month to a year prognosis. Our MDS coordinators, they're wonderful as far as identifying patients with changes in their MDS and their increased care needs. So we're going to switch a little bit. We're going to talk about the 4 levels of care. So let's test your knowledge. and see who knows all the 4 levels of care. Oop, I just gave it away.
Doesn't look like we have any answers for this one.
Really? I might have found something to stump you? Well, I gave one away because I described that most patients are on this level of care. Unless I put everyone to sleep already.
Maybe palliative care.
All right, we have maintenance and end of life, routine. So somebody was listening. Maintenance, palliative, end of care, wide awake. Thank you, Deb. All right. So there are 4 levels of care, and we will go through them. And this is good. I think you guys will get something out of this. So routine level of care is what most patients are on. We also have crisis care or intensive comfort care. There's inpatient care or general inpatient unit and respite care. So this might be an unfair question because we didn't know the levels of care, but which levels of care can be done in a nursing home? The answer to this is all levels can be done in a nursing home. And we'll go through this. Which levels can be done in an assisted living facility? Good, Donna. I saw you got all. So which levels can be done in an assisted living facility? Which is similar to a home, residential home or private home. This will be just 2, routine level of care and crisis care. So let's move on to our levels. So routine level of care is the most common level of hospice care in the United States. Right now on my hospice, we have all our patients are on routine level of care except one patient. I have one patient on crisis care right now at an assisted living facility. Routine level of care provides the core services are provided by the interdisciplinary team that we reviewed. A patient's home could be their private home, assisted living, a group home, or a long-term care facility, wherever the patient lives. These patients are getting care based on their care plan. So that's when the nurse is going out to see the patient 1 to 3 times a week. The patient may be pretty steady. So the nurse may only go out once a week to check meds and check vitals. Or the patient may have a stage 3 pressure ulcer. And so now we're doing dressing changes 3 days a week. So the nurse may have to do a dressing change 3 days a week. That patient is getting a hospice aide. That aide is doing, whatever was determined by the plan of care. They may be providing the showers 3 days a week, or one day intermixed in there. They may be helping feed the patient. Then the patient is getting access to social work, chaplain, and possibly volunteer, where the volunteer program may have the paw pets where a dog could come in, or somebody sitting there and reading to them. So routine level of care is when the patient is not in crisis. They're appropriate for hospice, obviously, but they're being managed, and we have not hit any type of crisis where we need to move them up to a higher level. Another level of care is respite. Respite is a short 5 consecutive days of inpatient care. It's oftentimes caregivers will schedule respite because they need to travel or they need to rest themselves. They may have to go to a doctor. We had one gentleman who had a wife with advanced dementia, and he went on a fishing trip every summer. So he needed respite. So these patients can be placed in respite as often as every benefit period. We've had some patients even utilize it once a month. It unfortunately is the most underutilized level of care. A lot of people, especially home patients, are afraid to not be there. They are afraid that the patient may die when they're on this fishing trip, and so they won't take advantage of this. Um, when the patient is in respite, it's the hospice's financial responsibility to pay room and board to a nursing home where the patient is placed for those 5 days. And then the hospice team basically just moves their location and they do all the same stuff they were doing before. They're just now doing it in that nursing home for the 5 days they're on respite. The next two are higher levels of care. The first one is continuous care. So, this is when a patient has symptoms that are needing more intense surveillance as well as change in meds. So, the hospice provides a minimum of 8 hours of care during a 24-hour period. That's what Medicare requires. Now, some hospices, including mine, will try to cover 24 hours because when the patient's in crisis, the family's like, you're leaving, you can't leave. But really, Medicare only requires 8 hours. And you can even split up that 8 hours by doing 4 in the morning and 4 in the evening. It has to be provided by an RN or an LPN, and it cannot be custodial. So it cannot be, oh, the patient is trying to get out of bed and I need a sitter there because I, need to get some rest. It's got to be a symptom that's being managed, um, and vital signs are needing to be done, and intervention is need to be put into place. So the patient may be short of breath, and we may need to be giving breathing treatments and giving some meds to help with shortness of breath. Or they may have terminal restlessness where they're trying to get out of bed and we're keeping them from, falling. And so they may need some Haldol. So there's got to be an intervention during this time to warrant this higher level of care because now the Medicare is paying that hospice upwards of $800 a day to take care of this patient. Whereas remember, we talked about routine level care, which was what, 180. And I'm just throwing out numbers. It's approximate and I haven't looked them up to be honest with you, but the price differential is significant. So for a patient to be on crisis care, they need to have the documentation to support it. Um, Otherwise, that Medicare is going to say, yeah, I'm not paying for that because you weren't providing a higher level of service. The same criteria that constitutes putting a patient on crisis care is the same for general inpatient. So general inpatient is either done like in a hospice house where we see a patient admitted at the hospital and they're too unsafe to go home and they may die in transport. So they're put into a hospice unit and they may have, less than 5 days to live and they need to keep their symptoms under control. So they go into the hospice house. We also have an ability if we have a home patient and the family does not want to do crisis care at home. They're overwhelmed. It's maybe too complicated, whether we have to start an IV on the patient, things like that. It may be better suited to put the patient in a nursing home on a GIP bed and take care of the patient there. This is not respite. This is a GIP bed. The nursing home staff would be taking care of the patient. during that stay, as well as the hospice team being there as well. So these higher levels of care, there's two. We talked about continuous comfort care and GIP. The criteria for eligibility for these levels of care are the same, need to be periods of crisis. So the place of where it occur could depend on the patient and family's choice, the resources and availability of the hospice, or depending on the complexity of the interventions. Too unstable to transport, so they go into the hospice unit, or if we need to do IV pain medication in the home, it may be unsuitable for that. So what is a crisis? A period of crisis is defined as a time when the individual requires continuous care to achieve palliation or management of acute medical symptoms. These can be new symptoms or exacerbation of chronic symptoms. So it could be a new pneumonia. During COVID, we placed patients on these higher level of cares for COVID, intractable nausea and vomiting, uncontrolled pain, and we're starting a new med such as methadone, delirium and restlessness, transitioning to death. The key word for that is the patients have to have an uncomfortable transition to death. Some patients die very peacefully and they just stop eating and their vital signs are perfect and they just need turned every 2 hours to prevent a bed sore. That's not a crisis. And unfortunately, Medicare will not pay for that hospice to be at bedside, possibly for that death. COPD and CHF exacerbations are a perfect example of crisis. These levels are brief. They require daily reevaluations of the crisis. It's a physician's order to initiate and discontinue higher level of care. Once the symptoms are stable, the patient returns to routine level of care. Now, patients can move back and forth from routine level of care to crisis care depending on symptoms. So we may have a patient that's transitioning and they have a high respiratory rate and they're in pain. That's an uncomfortable death. We put them on crisis care, put a nurse at the bedside, and get their symptoms well managed. Now they're breathing at a respiratory rate of 18 and their vital signs are stable and they just need turned every 2 hours. Well, we may need to put them back to routine level of care at that point. But then they start 2 days later having lots of secretions. So then we could bump them back up to crisis care to manage that crisis. So dying does not always meet criteria for high level care. And all of us would love that death, right? We don't want to be in crisis prior to dying. So once crisis symptoms of transitioning are managed on crisis care, the patient may need to return to routine level of care. So now we're getting to the end of the lecture. Higher levels of care can keep your patients out of the hospital. So the two big ones I think of for helping you keep your patients in their beds is those patients with CHF and COPD. Because what do these two types of patients have in common? They have a trajectory with exacerbations. This is the congestive heart failure trajectory. You see that the patient is having these downward spikes. Those are exacerbations of CHF. And the first two probably resulted in a trip to the ER. The ER really didn't do much because unfortunately, they can't adjust any of the meds. They probably gave the patient some morphine, some oxygen, and some nebulizer treatments, checked their blood levels, but the family doesn't want, any further intervention. They come back, but as you see, they're at a lesser functional status than they were before. So there's a downward of those flat lines. Once we start seeing that they're coming back from the hospital, not in, in a less shape than they went in, they're starting to have that terminal decline of the illness. And the big fat black arrows is the time we start needing to think about putting them on hospice. Then, when they continue to have those downward spikes, we can, instead of calling 911, having them go out to the hospital, we can put them on crisis care. And during those exacerbations, the crisis care team at your facility, the nurse and the hospice doctor, can work with medicines to get them through that rough patch and get them feeling better. Then they return back to routine level of care. And as you see, they're not at the same level they were before. They may have one or two more episodes which require crisis care until they die. And deaths from congestive heart failure are pretty sudden. So that's why it's a big downward. If we look at the trajectory for COPD, it's very similar. We see exacerbations of COPD. These, patients typically don't tolerate more oxygen, otherwise they're at risk for CO2 retention. So they're getting nebulizer treatments, they're getting steroid and morphine. These are all things that can be done on crisis care at your facility if they're on hospice. So again, when we start to see these exacerbations not allowing the patient to return back to their baseline and they have a trajectory of going down, we need to catch them and put them on hospice. So I kind of gave the way the answer on this because I know we have time is getting close. So what can be done in place of sending these patients out for exacerbations of their COPD or CHF? We can put them on crisis care. And so those are two good examples, your CHFers and CHF, to help keep patients out of the hospital. So how can hospice help you? The Medicare benefit covers 100% of costs related to terminal diagnosis, educates families and patients on advanced directives and DNRs and how to take care of their patients, manages pain, shortness of breath, anxiety, dysphagia, wound care, etc. Hospice can keep your patients from being readmitted to the hospital by lowering readmission rates, keeping your beds full, and allow patients to die in their place of choice, which is their home, your building, with your staff being there for support. Then I have references, and we'll just end with questions.
Thank you for a wonderful presentation.
Thank you.
At the time, if any of the attendees have a question, please feel free to unmute yourself or place the questions in the chat box. While we're waiting for anybody to chime in, I do have one question. Do you have any tools or processes to share for these hospitals to help educate patients and staff?
We do, as far as we have a lot of materials on hospice eligibility, and a lot of it is per diagnosis. So it'll give the criteria for what to look for if a patient, is end-stage heart, lung, has had a stroke, those sort of things. And most hospices will have a marketing sales team, and they are talking with social workers at the hospitals, trying to educate them, the discharge planners, because those are the people that kind of need to know what the options are for a patient's safe discharge. I'm always trying to get in front of hospitalists and people like that so that they're better educated on when, to have the conversation with the family. But there is a lot of literature, definitely on vitas.com, that we have put together for education.
So we can go to that website and just pull off education for, and mainly just for hospital staff to recognize when a patient may be more appropriate because, trying to avoid all these readmissions that the hospitals are seeing from, as the heart failure, COPD, et cetera.
Right.
Okay.
We also have an app. So there's a Vitas Healthcare app that you can put on your phone. And in the app, it'll have hospice criteria and it'll list it based on diagnosis. So that's a nice tool to have on your phone.
Do you have any recommendations for the hospitals on how to get with their local hospice so that they can come in and speak to their providers to be able to recognize hospice patients at a quicker than the 2-week mark?
Yeah. I mean, all the education you guys can and help is the best. And that's just like hospitals reaching out to the hospices that they use and see if one will come in and do presentations. Um, I know we do lots of presentations. There's even, um, we offer CEU credits as well to nurses and social workers on Hospice 101 and things like that. So, um, maybe there's a hospice provider around your area. Vitas is not in Kentucky, so that's unfortunate. But there may be a hospice provider that can provide that information.
And my last question, unless somebody else has any, would be, you talk about the 6-month mark, and then the patient gets recertified. So is it possible that they can be recertified every 6 months if it happened to the guesswork was a little bit off?
Yeah, and I didn't talk about that, so thank you for reminding me. So when a patient is admitted to hospice, their first benefit period is 3 months. So after 3 months, the interdisciplinary team, will sit down and review the patient and determine whether they're still meeting criteria for hospice. So we're looking for weight loss, decline in functional status, needing more help with ADLs. And if that all matches, then they're recertified. And then they get another 3 months. The end of that 3 months, it'll now be 6 months. And so at that time, the team will again determine if they need recertified, if we're able to keep them on service. Once they've been on service for 6 months, the recertification periods are every 2 months, 60 days, and they require a face-to-face to be done by the hospice doctor or the hospice nurse practitioner. Um, and that's just upping the ante. Medicare is now saying, well, the patient's been on 6 months, so now we really want a physician or nurse practitioner to put eyes on the patient and make sure they're still appropriate. And that kind of limits those patients being on hospice for, 2 years, 3 years, 4 years, which is not, that can happen in a very slow decline of a patient, but that should not be a large percentage of any hospice having those long length of stays.
Well, thank you. Is there any other questions? Well, if there's no further questions, I'd like to thank everyone for their attendance and participation. And thank you again, Dr. Greenstein, for sharing your expertise. And
You're
on behalf,
welcome.
and on behalf of the Kentucky Hospital Association, I'd like to wish everyone a great day.
Thank you.
Thank you.